Assalamu alaikum wa rahmatullah. The article of this week is a case report titled Invasive Oral Squamous Cell Carcinoma, mimicking a dentoalveolar abscess report of a case in a 14-year-old patient. It was done by Stevenson et al. In 2024 and published in the Journal of Endodontics. So this case report highlights the importance of accurate diagnosis in dentistry, particularly when odontogenic pathologies are ruled out. So also it describes a rare presentation of oral squamous cell carcinoma in a 14-year-old patient. So the incidence of squamous cell carcinoma in pediatric and adolescent populations is extremely rare and make up only 0.2% of reported cases. And it's most often found on the tongue or lips, but can also be found in the maxillary gingiva or alveolar mucosa. And when oral squamous cell carcinoma lesions arise on the gingiva or mucosa, the initial clinical presentation may mimic endodontic or periodontal diseases, making accurate diagnosis challenging. Also, it may initially present as a herpetic lesion that doesn't resolve in expected time frame. So the patient is a healthy 14-year-old male with a chief complaint of sensitivity in the area of tooth number 7. There was no clinical evidence of extraoral or intraoral inflammation. A PA radiograph showed no evidence of pathosis, so the patient was referred to the oral and maxillofacial surgeon, and he recommended an observation for the patient. 8 months later, the patient returned to his pediatric dentist with a raised soft ovoid sessile erythematous swelling on the facial gingival mucosa with focal light yellow areas of surface irregularities facial to tooth number 7 and extended to the distal aspect of tooth number 7, and it was 1.5 centimeter in diameter, and there was no exudate. For the PA radiograph, it shows that the clinical crowns were intact and the interradicular bone resorption was noted between teeth numbers 7 and 8, which extended from the alveolar crest to the apical third of both teeth. The PDL space was markedly widened. Then the patient was referred to an endodontist. Teeth were mildly tender to percussion and palpation, and the Cole test resulted in rapid, pronounced, short duration responses from all 6 maxillary anterior teeth from 6 to 11. So a preoperative endodontic diagnosis was normal pulp with symptomatic apical periodontitis. And this diagnosis was for tooth numbers 7 and 8. CBCT showed a well-defined unilocular area of low radial density with non-corticated borders involving the periapex of tooth number 7, the interproximal bone region between teeth number 7 and 8, and the distopalatal aspect of tooth number 8. Also, there was an erosion of the facial and palatal cortical bone. Then patient was referred to do an incisional biopsy, and the histopathological diagnosis was a well-differentiated squamous cell carcinoma. A p53 immunostain was obtained that was diffusely positive in many areas, suggesting a p53 mutation. After that, an anterior maxillary alveolar resection was performed, which included the removal of teeth number 6, 7, 8, and 9 as a treatment. After 4-year follow-up, all scans made at follow-up examination have been confirmed clear with no signs of cancer present. So this case report illustrated that without a careful clinical examination, a clinician may misinterpret a gingival swelling with an associated periapical or periradicular radiolucency as a lesion of endodontic origin. And it also highlights that when a patient is experiencing symptoms and no clinical or radiographic pathosis is noted at the time, the patient should be placed on a structured recall schedule and closely monitored, especially when symptoms persist. Although endodontists primarily treat inflammatory disease processes, they must be vigilant to properly recognize lesions that mimic those of endodontic origin. Biopsy and histologic examination should be considered to confirm the diagnosis of all lesions that demonstrate unusual signs or symptoms.